Hi, my name's Bonnie Morris, and today I'm going to be doing my Capstone project for certification in functional manual reaction. I'm in the gift class of 2017 with the Gray Institute. My subject is my sister Carolyn, and Carolyn had last year, the end of last year, she ruptured her posterior tibialis tendon and had ended up having surgery March 13th of this year. She had a calcaneal osteotomy and a flexor digitorum longus tendon transfer. She was casted for 8 weeks, non-weight bearing, and then was non-weight bearing another 3 weeks. So in total, she was 11 weeks non-weight bearing, then 20% weight bearing for a couple of weeks. So basically, she's been about 3 months with the ability to fully weight bear. She's been going to physical therapy twice a week for the past a little bit more than 3 months. I am not her physical therapist, just location, time. And she's done a fabulous job. The therapist has done a fabulous job. But there's still some underlying issues going on. And Carolyn, why don't you tell us what still happens? And this is her left foot and Carolyn's left hand dominant.
So what happens is the discomfort comes in right through the midfoot here mainly, and up into this, right at this area here, where it feels like sometimes it's pulling on my big toe. So when I walk, I feel like I can't complete the step comfortably. So at times I'm still limping.
Okay. Yeah, and we can see that sometimes. You know, she's able to walk a good distance, but yeah, even Carolyn walking in today in her sneakers with orthotics, and the doctor told her she's always going to need orthotics. I could still see that limp there. So I've done 3D maps, and with the 3D maps analysis, I noted with the anterior chain that Carolyn was lacking dorsiflexion of the left ankle, a little bit of hip extension. The opposite side lateral chain, she was lacking left supination and calcaneal inversion. And with opposite side rotational chain, same thing. She was lacking calcaneal inversion and forefoot, midfoot supination. She also had a little bit of restriction in her thoracic spine, type 2, on the right. But for today, we're just going to focus on her midfoot, on her midtarsal joint, to try to loosen that up. Okay, so right now I'm going to do some testing right through here, do a little bit of simple side assessment, and then do some functional test, reach test, and we'll see what we've got going. So Carolyn, I'm going to have you come up here. And so maybe if you can come up and just first even get a little zoom in a little bit on Carolyn's feet and even right through here. Okay, and Carolyn, what I'd like you to do is I'd like you to roll your feet, roll your arches up, okay? And come back down. And maybe Shannon, if you can come in here and just from the front, just kind of get, when she does that again, kind of get how much she gets through here and then how much she gets in this area. And as we can see, Carolyn's medial foot is also just, it's coming off the ground through here. How about Carolyn holding your arms out in front of you? And I'm going to use a top-down driver. I'm going to have you swing your arms to the left. What this is doing, it should be creating some calcaneal eversion on the left. And Shannon, I'm going to have you come back this way again. Carolyn, you can let your arms go forward. Okay, arms out in front of you again, and swing your arms to the left. And come back down. And one last time, swing to the left. Good, and come back down. And I'm sorry, one more time, can you do that? and come back down. So I'm really not feeling too much movement through that subtalar joint. But what I'm going to do, just to really isolate her mid-tarsal joint, I have a little wedge right through here. And Carolyn, what I'd like to do is just slip it under the inner portion of your heel. So I just have, I'm pre-positioning Carolyn's heel in inversion, and I want to see what happens at her mid-tarsal joint again at this point. So Carolyn, I'd like you to try to roll your arches up again, or roll that arch up. And again, you can see that she's unable to keep her forefoot down. Again, try to roll it up, and if I do that, hold her foot down on the medial side. She's really not able to get much movement. And you can relax. And one last time, roll up and relax. Okay, I'm going to take this out. Okay, so now what I'm going to do is I'm going to have Carolyn do some reach test, and then we're going to do some stability test. And so basically, you know, Carolyn's, her foot is staying in, her calcaneus is staying in eversion. Her forefoot, it's staying pronated. And in the TZ2, she's unable, I've been able to see even through gait, she's unable to lock, to have that midfoot lock out. So I think she's lacking in some dorsiflexion of her ankle. And so what has to happen, her mid-tarsal joint is staying unlocked and staying loose, number one, so she can get that dorsiflexion through there. But also I think that her midfoot, her mid-tarsal joint is really tight, and it doesn't even have that available range of motion to be able to lock up and to provide Carolyn with a stable foot to push off of. So the first thing, Carolyn, I'm going to have you do is keeping this foot right here. And so let's see, the toes pretty much right in the middle. I'm going to have you reach first, or actually lunge out to the right here. Good, right on that line. Good, come back. Now I want you to go as far as you can. So you can see her foot is going into, good, come back. She has calcaneal eversion. Her mid-tarsal joint would be, as Gary says, wiggly wiggly. And that's just, you know, when we go into calcaneal eversion, when we take a step, calcaneus goes into eversion, the midfoot unlocks so that we can accept various, you know, structures from the ground. We can walk on uneven terrain. So now we're going to have Carolyn come over so that she's going into, should be calcaneal inversion. So you're going to come across. Good. Come back. Okay. And take a reach across as far as you can. Good. Come back. And you can even see that Carolyn kind of do it one more time. What she's doing is she's really bringing her whole body over here. She's not keeping her tibia even in line as much through there. I think she's doing a little bit of a bailout. So come back, and I'm going to have you do one more time, and I'm just going to mark it. So you're going to come across here, okay, and I'm just going to mark it. Okay, come back down. Afterwards, I'll take a measurement from the middle to here, so we can get a pre-positioned measurement. Next, Carolyn, what I'd like you to do on your right, you're going to keep your left foot planted, and I'm going to have you do a reach out to the right, okay? And again, because we have calcaneal eversion here and the midfoot is unlocked, we can get some midfoot dorsiflexion. So we're going to be able to get more motion right through here. Carolyn, can you do it one more time? Good. Come back. And one more. Good. Next, what I'd like, Carolyn, for you to do is to keep your left foot planted and to come across this way. So we're looking for some stability and to see how much motion. Now, normally you really wouldn't get as much motion because, again, with the calcaneus coming into inversion, what that should do is lock that midfoot up so that you don't have that relative, well, the midfoot, the mid-tarsal joint is relative dorsiflexion from the rear foot. Because it's staying on the ground, it's really if I took it off the ground, you'd have plantar flexion, but because it's staying on the ground, you have the rear foot's coming up and you're getting relative dorsiflexion. So Carolyn, come out again. Good. And again. And one last time. Okay. And I'm going to mark that. Okay. Okay. So I have Carolyn up on the table here, and even though my concentration today is going to be on her mid-tarsal joint, I know that we have to work her subtalar joint first. That has to be loose. Basically, what I think is going on is Carolyn's mid-tarsal joint is just really locked down. It is not allowing the subtalar joint to invert, because if the subtalar joint at TZ2, when her forefoot's on the ground and her heel starts to come up, and it should be pulling up and locking that mid-tarsal joint, because that's locked through there, the subtalar joint knows that if this mid-tarsal joint doesn't have that mobility, it's going to, the medial side of her foot is going to lift off the ground. And most of us do not walk that way. That's not a normal way of walking. So Carolyn stays down into pronation. Her subtalar joint is not inverting well. So right now, just to simulate TZ2, I would have Carolyn's knee, I'm having Carolyn's knee extended, slightly external rotated. And so what, you know, in the gait cycle, you have a TZ2, that right, if her left heel is on the ground, you have your right hip coming forward and rotating to the left. And because it's a top-down driver, it is, although you get relative internal rotation of the left hip, really what's happening is the real bone motion is external rotation of the femur, which is going to drive the tibia into external rotation, which is going to drive the calcaneus. It should be going into inversion. That talus will be coming up externally rotating, and that'll also then lock the midfoot out. Stop. Okay, so what I'm going to do right here is I'm going to grab the navicular and the talus, and just going to do some easy FMR of the subtalar joint just for a couple of minutes. I'm going to, almost like a ringing effect, I'm going to externally rotate her tibia and also pull that talus up and the navicular up over the calcaneus. Okay, so I'm going to do that just for a couple of minutes, kind of loosen that up to make sure that I can get that mid-tarsal joint motion going. So again, we're getting relative external rotation of the tibia on the calcaneus. Now also to check, if I wanted to check the midfoot, I could bring Carolyn into subtalar joint neutral, kind of line up that toe, second toe with the middle part of her tibia, and I could check her eversion and her inversion. And it actually doesn't feel that bad through here. But again, now I'm going to go down and I want to get into the mid-tarsal joint. So what I'm going to do is I'm going to bring her calcaneus, I'm going to take it and I'm going to pull it into some inversion. Again, we're trying to simulate and be authentic to TZ2. And the first plane of motion within the mid-tarsal joint that I'm going to check is the frontal plane. So if my rear foot of my subtalar joint, if my calcaneus is inverting, my midtarsal joint should be everting. And you can see Carolyn has very little, if any, if I can feel, midtarsal joint eversion. So what I'm going to do for FMR is I'm going to bring her midfoot down into some eversion, and I'm going to hold it there. Again, to simulate the midfoot, the forefoot would be on the ground during TZ2, and I'm just going to do some easy calcaneal eversion. Carolyn, you feeling okay?
Yes, thank you.
Carolyn's heel, just the incision, it can, it's pretty hypersensitive. You all right?
Yes.
So again, I'm just going to take in that calcaneus, relax again for a second, sorry. I'm going to bring it into inversion, her midfoot, midtarsal joint, I'm going to bring it to eversion and hold it there. And again, I'm just going to do good, some easy motion. Sure you feel okay?
Yes.
Okay. And this is something, the midtarsal joint, when it's tight like that, this isn't something that a patient really can do, a person can really do on their own. So FMR is really going to be critical in helping Carolyn get some of this motion back so that she can have a really nice stable foot during push-off. The longer that heel stays on the ground, you're going to get a better load of the butt, the front butt in TZ2 to have the swing through. Okay, the next one I want to do for the midfoot, for the midtarsal joint is, again, I'm going to bring the calcaneus into inversion, and I'm going to check, okay, I did the frontal plane motion here, and so I'm going to do the transverse plane. Her midfoot, her midtarsal joint should be adducting, okay? And again, this is pretty darn tight. Are you sure you're okay, Carolyn?
Yes.
So I'm going to try to hold this midtarsal joint into adduction, and I'm going to keep just doing some easy calcaneal inversion. I would also, I know we're just doing really the midtarsal joint. I would also be checking Carolyn's, and I have her great toe extension, and that definitely is limited. But again, for today, we're just focusing really on this midtarsal joint. So I'm holding it into adduction, and let's see if I'm getting some more motion. Can you feel that, Carolyn?
Yeah, I can.
Feel that motion more?
Definitely.
Yeah. So we're getting some more of that frontal plane motion just from loosening up that transverse plane motion. Okay, the last that I'm going to do is to check her sagittal plane. So the forefoot would go into plantarflexion, but because it stays on the ground, it's really that the rear foot is dorsiflexion. You're getting relative dorsiflexion of the midtarsal joint. So again, what I'm going to do is to bring her calcaneus into inversion. I'm going to bring her foot down into plantarflexion, and I'm going to try to drive it up and down. Drive that rear foot. I'm going to hold it here and try to drive that rear foot up. You feeling okay, Carolyn?
Yes, thank you.
Okay. Okay, so just a couple more minutes. So lastly, I'm just going to bring her into inversion again. And one last time, I want to check and look at, you can see through here, she now has some nice, well, much better, I should say, eversion of her midtarsal joint. She has some better adduction. And right here, she would have some better plantarflexion, or really it's relative dorsiflexion of her rear foot on her mid-tarsal joint. Okay, holding on.
Yep.
Okay. Okay, I'm going to do a little FMR in standing now. We did obviously some up on the table, non-weight bearing. And what I did just for ease, almost kind of to simulate a true stretch, I have a little wedge here and I'm pre-positioning Carolyn's foot, her calcaneus, into inversion, kind of like a bottom-up driver here. I have her leg up, her back knee is extended, and so what I'm going to do right now is I'm going to start using a pelvic driver. Also, I have her midfoot a little bit in eversion through here, okay, and I want to simulate also a true gait pattern, a true TZ2. So I'm trying to make sure that she doesn't rotate her shoulders. Okay, so we're just using this pelvic driver. And again, her pelvis would be rotating to the left. And what's going to happen, it's going to take this femur and bring it into external rotation. So I could do some FMR here. And I could do some FMR right here on her femur, bring it into external rotation. Also, I could, looking at bringing her tibia into external rotation. How you doing, Carolyn?
Good.
Okay, you feel stable?
Yep.
And so what I'm going to do, I could also just keep my, are you okay with this pressure?
Yes.
I'm just trying to easily, just trying to drive her calcaneus a little bit more into inversion. And at the same time, instead of lifting up or doing anything to her mid-tarsal joint, I'm really going to push it into the ground easily so that we get some relative eversion in the mid-tarsal joint. Good. A few more of those, Carolyn. Also, what I could be doing is taking the talus and the navicular, kind of grabbing them and kind of driving them up, external rotation and dorsiflexion. You doing okay?
Yes.
And again, I'm holding this medial part, her midfoot down, so I'm getting some get some relative mid-tarsal joint eversion. Keep going. And lastly, I could just hold her tibia into, try to get some more dorsiflexion here while I easily do some FMR into tibial external rotation. Kind of just feather this tissue. A couple more. And just, again, I'd be watching that hip a little bit more. Okay, good. Okay, so now after performing FMR, we're going to do we're going to recheck, see how Carolyn did. So the first actually, let me just see you again. Try to roll your feet up. Good, and come back down and roll up. And she's still lifting medial side there. Okay, one more time. Roll up. Try to keep that toe on the ground. Okay. Next, I'd like you to take this your right foot, and before she did 27 inches, and so I'm going to have you come over. That was this dot right here. Okay, come back, and again, as far as you can go, come back, and one more time. There you go. Okay, come back. Okay, and next I would like you to do a toe touch. So you're going to bring this foot over, and you're going to toe touch. Beautiful. And come back and do a toe touch. Awesome. Come back one last time. Toe touch. Good. Come back. Okay. Okay. So the results of the test. When Carolyn did the lunge, she improved an inch. So it's showing that the mid-tarsal joint had a little bit more motion to to allow it to lock up, a little bit more dorsiflexion with inversion. The second test, when she did the reach, she actually gained 3 inches, which was beautiful. That's really showing she's getting more dorsiflexion with inversion, which again, what that comes down to, she's going to be able to keep that heel on the ground a little bit longer if we can get that dorsiflexion, lock that midfoot up to create a stable foot to propel off of, to be able to load that front butt. So now we want Carolyn to be able to maintain these things at home and to have a little bit of a home exercise program. So I would like to start always with success. So Carolyn is more successful. I'd start her in less dorsiflexion and more plantarflexion. So I'm probably going to have her do just a little towel at home, or I can give her this wedge. And I'm going to, just like we did for the FMR, I'm going to pre-position her with her calcaneus in inversion, and I'm going to have her just do either some knee drivers or just some pelvic drivers also, just to work on that motion. So let's have you come here, Carolyn. Good. And so let me just get your foot, okay? A little bit more. Bring your forefoot. Sorry, lift up your heel again. Good. So kind of like we did before, you can put your foot up on a step, or just
just drive it?
Yep. Right, just drive it through there. Good. And you want your knee straight. Good. Okay, so I would have you do like 5 or 10 of those. And then if you can, I'd like you to take the support away for your arms and just try to do a little bit more of a balance. So you're going to try to do, you do support that you need. If you need to hold on, that's fine. Okay, I would progress Carolyn again to a bit more into dorsiflexion, so she can get that dorsiflexion with inversion. That's the first exercise. The next exercise that I'm going to have her do is, I'm going to take this out, is just to get those calves going in an econcentric way, specific to TZ2. I'm going to have her use a nose driver, a head driver, and if this was, she can do the wall, nose to wall. Okay, and she's going to come in and try to control that dorsiflexion there. And I'm going to have her start closer into the wall, and as she becomes more successful, bring her out further so she has more dorsiflexion to go through, and then as she even improves, do toe touch and have her even do one-legged. Okay, let's have you show that. So come in a little bit closer, Carolyn. Okay, so you're moving through your heels. Think of your nose coming into a wall. Good, come back. Good, and can you feel your toes kind of clawing down?
Yes.
You can feel your, good. Great, okay, come back down. How do you feel, Carolyn?
I feel good.
Okay.
It feels looser.
Okay, great. That is my capstone project for Gift 2017. Thank you very much, everybody, for all your help. I appreciate it. And if you have any questions, let me know. Thank you. Bye-bye.